I'm going to be exploring today some of the issues involved in implementing hybrid interventions. What are hybrid interventions? Hybrid interventions are those which include both common and variable components, and they are increasingly used in recognition of the need to enhance the fit of interventions to their delivery settings. But they also retain a notion that there is something, an intervention, being delivered that has been designed externally and could be delivered elsewhere. So the aim is to achieve success at scale, whilst also being sensitive to context. That said, they bring challenges. Allowing flexibility in terms of what is delivered could mean that important intervention components go undelivered, and also intervention complexity itself can complicate implementation efforts. A further question is how we go about evaluating hybrid interventions. So there is some criticism of established evaluation frameworks that they downplay the challenges involved in evaluating complex interventions that could potentially take on a very different form in different settings. I'll be exploring some of these issues through a feasibility study involving a hybrid intervention being developed for a trial. The feasibility study is part of the PACT study, a 5.5-year NIHR-funded study to explore transitions from hospital to home, with a focus on older patients. The study has involved 6 stages, including stages exploring patient experience of transitions, best practices in terms of how wards prepare patients for discharge, through to the design of an intervention, a feasibility study, which is my focus today, and then eventually a full trial. What emerged during the early stages was a sense that patients, when they go to hospital, effectively cede decisions about themselves and their care to hospital staff, and for good reason, as they've been hospitalised and are unwell. However, when they leave to go home, patients then take up responsibility for themselves and their care once more, and they can struggle to do this. The PACT research team modelled the transition from hospital to home, and this revealed certain core activities or functions which patients perform after they return home that are key to a successful transition. These are maintaining their health and well-being, doing activities of daily life, safely using medications, and escalating if things don't go as planned. There is variation in the extent that patients can perform these functions at home, and variation in terms of what hospital staff do to prepare them, with patient involvement being critical. So this implies the possibility of an intervention on the assumption that enhancing how patients are supported to prepare through patient involvement may result in improved patient outcomes at home. The intervention includes certain core patient-facing components, including a Your Care Needs You booklet that I've got right here. So this includes some key bits of information that's useful for patients to know, along with some prompts of questions that patients may like to ask of staff. So this information and the question prompts are mapped onto the 4 functions that I discussed on the previous slide. So health and well-being, medications, keeping moving, and getting help. Where to go to get help once patients get home. A film and poster display emphasise the importance of taking on a more active role within the hospital setting where that is appropriate, while a patient-friendly discharge letter provides information about what has happened to patients and what patients can expect when they get home. From the start, it has been recognised that these patient-facing components will be insufficient on their own. There's a role for hospital staff to support patients in using the intervention, and therefore various staff-facing components, including a training package, have been developed to guide staff. The research team has also sought to build in flexibility both into the intervention and the implementation strategy to allow adaptations to take place, building in the notion of a hybrid intervention. For example, each patient will be different, with different needs, preferences and circumstances, and therefore the contents of their questions will differ and will require a different response from staff. For reoccurring questions, ward teams will be supported to make a more concrete service improvement, which will again vary by ward. Ward teams will also be free to decide how they go about implementing the intervention, and that will be determined in a key ward level meeting at the start of the project work. The aim of the feasibility study was to explore the feasibility of the Your Care Needs You intervention and the implementation strategy, as well as inform their optimization. Research activities were concentrated on 5 diverse hospital wards across 3 NHS trusts that were testing both the trial methodology and the intervention. Diverse data were collected from observations, interviews with staff and patients, and the researchers kept reflective diaries. This created a lot of qualitative data, and a number of methods were used to analyse it. So I will present here the result of a thematic analysis, with themes summarised to convey the core learning of the feasibility study, and a real-world logic model of the intervention. So these logic models try to present the dynamics of complex interventions within their delivery settings. On the first theme, staff and patients generally liked the intervention. A common refrain from nurses was how it reminded them of how nursing used to be like when there was more time for rehab. Patients too generally liked it, although when was an appropriate time for patients to have it explained to them and be supported to use it differed in light of their health stage, which could fluctuate daily. And there was a need to involve carers and families where there were any capacity issues. There were obstacles encountered in a busy hospital ward where staff had little time and competing priorities. Some wards got bogged down on the delivery of the intervention components, and the ethos of the intervention, as something that was supposed to facilitate patient involvement, got lost. The learning from that was the implementation strategy, which hinged on the key ward level meeting that took place at the start of the project work, had left it too late. That's what the second theme is tapping into. The process of forming a team to support delivery should begin earlier on during study setup and should involve non-ward staff, for example volunteers or quality improvement personnel. Having them take on some of the basics of intervention delivery would free up staff time to focus on how they might support patients' use of the intervention. The lack of staff time to engage did differ across different wards, and staff training has to adapt to that. Ideally, staff need a detailed explanation of the intervention, and they need to work through with the research team how they can respond to their patients' unique needs and preferences. But where time is short, that isn't possible to do, and a brief explanation with clear guidance of what staff can do to support the intervention is required. But that is potentially problematic because it is difficult to achieve when time is so pressured, and there is a risk, given the limits on staff time, that it does become a tick box exercise. Much of the working through with staff would help with an extended embedded period, which is on to theme 4, and all of this requires extensive and proactive facilitation. So prior to intervention delivery, working across organisations to form the team, and also overcoming any barriers experienced during the intervention's delivery. So these barriers can relate to staff engagement factors within the inner context of the ward environment, or relate to wider organisational factors. So this kind of work can rub up against other trust initiatives. So keeping patients moving, for example, which is a core part of the booklet and a key function, can rub up against, for example, falls prevention initiatives. And there may well be some escalation work required by the research team to give staff more support and autonomy to keep patients moving when that is appropriate. So that implies proactive facilitation throughout intervention delivery. This is an attempt to express this complexity in a logic model. The model contains the key features of context, differentiating between the inner context of the ward at the bottom and the outer context of the wider organisation at the top. These factors were identified in the qualitative data as shaping intervention delivery and may require a response by the research team to either overcome them where they are experienced negatively or leverage them where they are experienced positively. The large oval in the middle expresses how the intervention is trying to shape staff and patient interactions. The core intervention components, so the booklet, are to be used flexibly. They are important, but only as boundary objects. The important bits are the active engagement and input of staff and patients. And the work prior to that by the research team during the study setup, so to the left of the oval, of pitching to senior leaderships, forming an organisational-wide team, and then providing assistance and support throughout. This is about creating the conditions for the intervention to be successfully delivered. That implies a stage of system-level adaptation, followed by a stage of patient-level adaptation, where the intervention components are delivered and used by staff and patients. And the outcomes to the right of the model, these may emerge to the extent that the implementation strategy successfully adapts the intervention and the approach across these different stages. So what a model like this can do is that it can focus the attention of implementers to assess whether they are taking into account the key features of context that will moderate both implementation and outcomes. And it also orientates evaluators to assessing the fit of hybrid interventions within their delivery settings. So what are the implications of the study? It confirms really the case for hybrid interventions, that it is important to flex to both interventions, to organisations and ward settings, as well as to patients' needs and preferences. But it does highlight some challenges in the context of a trial and where acute staffing pressures are present. In a trial, the resources available to the research team to support wards is constrained because of the numbers of wards involved. And there appears to be a unique challenge with these types of intervention, that is, they can risk becoming a tick box exercise, and the underlying ethos is potentially sidelined because of the constraints on time. That we're able to identify and talk about some of these challenges is evident of a further implication, that significant learning can be derived about how to implement hybrid interventions during the early stages of their development. Now, implementation science tend to assume that tricky social questions about implementation in the real world come to the fore after the trial stage is complete. But the study shows that these questions are increasingly being explored and addressed during the early stages of intervention development. And I want to propose that real-world logic models can help researchers capture the learning, refine it, and express it for wider audiences. And they may help guide both implementation efforts and evaluations of hybrid interventions. Thanks.